This week on the BackTable Podcast.
The biggest one are the neurochecks, right? So if they're going to the ICU, which a lot of the patients are, not a lot, but some of these patients are already in ICU because they're intubated and whatnot, right? Neurochecks is probably the most important thing to look for, or to request, I should say, like 1 or 2 hour neurochecks, just to make sure there isn't any kind of neurodeficits, right? Knock on wood, again, I haven't had any issues like that, but the data is what it is with respect to the risk of stroke or neurologic compromise. That's probably the biggest one. Otherwise, same thing with the groin, checking the groins, upper closure and all that. So.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable Podcast.
Hello, everybody. Welcome to the BackTable Podcast. I'm your host, Dr. Baheti. I'm coming to you from Tacoma, Washington. I have the best guest ever on today. It's Dr. Alex Lam. He's an assistant professor at UCSF. He was also my co-fellow, just one of the smartest, coolest guys I know. Most chill, for sure. Dr. Lam, thanks so much for coming on the show.
Yeah, thanks so much for having me, Alex. It's great to be here. Appreciate the invitation.
Well, cool. Topic today is bronchial artery embolization. Is that something that you guys do frequently at UCSF?
Yeah, we do. We do. Being a tertiary quaternary center, we get a lot of referrals from institutions or hospitals across the SF and Bay Area for this procedure, usually in the emergent setting, nights and weekends, but we're always happy to help. Yeah, and we work very closely with our interventional pulmonologists, as well as the ICU docs and whatnot. So it's quite a comprehensive kind of program, so to speak, or service line when we do these procedures.
Awesome. Well, let's jump right into it. So why do these people come to you?
Yeah, so typically patients who come to us are ones with either chronic inflammation or they have massive, usually some degree of hemoptysis, whether it's mild, moderate, or massive. Hard to really say for certain because, patients don't always quantify the amount of volume that they kind of hemoptysize, so to speak. But typically, patients come in with some degree of hemoptysis through the ED, and they're evaluated by the ER doc, and then one reason or another, they decompensate either because of an episode of hemoptysis or whatnot. And when they have this episode of hemoptysis, they're usually to a degree intubated for airway protection or not, but usually they are when they go to the ICU. If they're not, they still are transferred to the ICU for monitoring. At that point, our interventional pulmonologists typically take the patients for a bronch just to see if they can temporize the bleed with, spraying TXA or whatnot. Maybe you can see the bleeder and manage it in whatever kind of bronchoscopic,
endobronchial, whatever, yeah.
Yeah. It typically works pretty well. Our interventional pulmonologists are quite good. Once they stabilize the patients, but typically get a CTA. We always kind of recommend a CTA if the patient is stabilized. And the reason we like to get a CTA, it doesn't really tell. As you know, it doesn't always show, and actually rarely shows any kind of active hemorrhage. But if it, what we're primarily looking for are any kind of targets, right? Any kind of enlarged bronchial artery, by enlarged, anything greater than, 2 to 3 millimeters or so, give or take. Any kind of tortuous bronchial artery, any kind of airspace consolidation that will suggest hemorrhage, things like that. And we're just looking for a target, right? We're just looking for something that we can kind of go after.
So is it kind of like GI bleeds where the faster you get to them after they bleed, the better your chances are of finding the bleed? Or is this because they already go through interventional pulmonology and then they come see you? Are you really kind of temporizing them so they don't have another bleed?
Yeah. So primarily, more the latter. So we want to treat them so they don't get another repeat bleed. Usually they're not on death's door. Usually, sometimes you get those patients who are intubated, have a bronchial blocker, things like that, and they're a little more eminent. That's definitely the minority of cases. Usually, when interventional pulmonology gets done with them, they're usually pretty stable. Thankfully. So it's typically just to prevent another bleed down the line.
Okay, and then in terms of the causes for why a patient would have a bronchial hypertrophy, do you mind if we kind of just go through those for our audience?
Yeah, of course. So it usually depends on where you practice in terms of globally or elsewhere. Globally, it's typically TB, and we have a number of patients that come from South America or other parts of the country, other parts of the world, who come in with hemoptysis, and chronic TB is definitely present here in SF and kind of Greater Bay Area. But aside from TB, we get a lot of patients CF or just bronchiectasis for whatever reason, whatever cause, right? So any kind of chronic infection, like chronic fungal infections, things like that. We get some patients who get hemoptysis in the setting of tumor or malignancy. That's a little less common in terms of patients that we treat with bronchial artery embolization. We certainly, but it's a different ball of wax, so to speak. And in those cases, we can definitely talk about it, but I'm much more concerned about any kind of bronchopulmonary fistula, anything that would be a little worrisome for our embolic going to the left side of the heart, things like that.
For sure, yeah. Oh yeah, we'll get into like techniques and all that stuff.
Yep. Mm-hmm.
Okay, so stepping back for a second, when you get called from the ER for massive hemoptysis, how confident are you that it's a bronchial artery as the source? Or is there a reason to believe that, I might have to go invest the pulmonary arterial system as well? And how do you make that distinction?
That's a good question. So we're not always 100%. If someone if there's someone with CF or someone with history of chronic TB, and you get the CT that shows consolidation airspace disease, which I think is pretty in line with hemoptysis, typically that we know it's from the bronchial artery, all right? As opposed to some patients where we had a patient the other day with the pulmonary artery pseudo. I think it was in the setting of kind of a fungal infection or fungemia. We can definitely see some kind of structural abnormality in the PA-gram or the pulmonary artery CT. But not always, And so there's always a question of, do we interrogate the systemic side first and then go down the pulmonary arterial side? Hard to really say for certain. But if it's someone who has, someone with a good history, that would suggest kind of a systemic source, then we can go down the road to a bronchial artery embo.
Cool. Okay, going back to kind of, you were talking to me about bronchial arteries. I don't know, I have like this one lecture in my head from fellowship talking about bronchial artery embolization. And I think one of the most important things that you have to talk about is the bronchial artery anatomy, right? Mm-hmm. So maybe just give me an idea of how you evaluate it first on the CTA, and then we'll go into how you do your procedure.
Yeah. So it's funny because I'm pretty sure where we were. I was
next to each other at that lecture. Yeah. I'm pretty sure I remember who gave it. Yeah.
Yeah. But it's no. I agree with you. I think that the anatomy can be quite complex, and I think we can spend a lot of time discussing it. But truthfully, it doesn't really play into how I approach the procedure, because knowing that X% of patients have one bronchial on the right side and two bronchials on the left, I don't think it really kind of makes a difference per se. I always get a CTA to look for any kind of targets, right? And I also do a flesh aortogram as well, to lay out this out. And a lot of people don't, but I like it. Especially before I kind of start poking around and probing the bronchioles, which can spaz and dissect, right? The only thing that really kind of important to know, at least on the anatomy side, is to know that there are non-bronchial kind of feeders, non-bronchial systemic feeders that kind of go to the pulmonary parenchyma, right? And so things like, feeders that arise from the subclavian, typically through the internal mammaries, all the intercostals can supply branches or feeders, inferior phrenic, things like that. It's important to know that up to, 20 to 30% of the bronchial arteries can be supplied by these kind of non-bronchial kind of arterial supply.
Okay.
And so it's important to look for those feeders when you do the procedure.
Okay. Yeah. Well, let's get into it. Tell me, okay, you got let's say your dude's intubated. You bring him to your table. First, let's talk about kind of setup.
Yeah. Okay. Let's talk about it. So we kind of touched upon this a little bit, but I think before we even have the patient in the room, I think talking about the consent and talking about the risks, right? Because I think this was something that was I'm sure you remember hammered into us during fellowship is the consent process and making sure we talk to patients about the risk of stroke, right? Or any kind of neurologic sequelae from the embolization, right? Because it's not a small amount, right? I think some studies suggest that it's as high as 5%. Which is pretty high. In this day and age, with the techniques of microcatheters and larger, kind of more precisely calibrated embolics, that risk may be a little bit lower. But, I do talk to patients about this 5% risk. And when I talk to patients also, it's the decision to pull the trigger. Some people would say it's based off of the definition of massive hemoptysis, which some people say it's greater than 300 in a 24-hour period or greater than 100 in 3 days. I don't know. I think we also talked about this in fellowship as well, is that the volume doesn't really matter so much, and because you can have a small amount of hemoptysis, but then still have clinical deterioration, right? And so this is all kind of discussed in the pre-procedural period. But yeah, to fast forward, to say patients, had a bronch, we know it's on the right side, or we think it's on the right side based off the bronch, and the CTA shows some good targets. Patient's intubated, unfortunately, for airway protection. I always go through the groin, typically. 5-French sheath. In terms of your diagnostic catheter, whether it's a MIC or SIM1 or Cobra, to me, it doesn't really matter all too much. I switch between the two. I do find myself going more towards a reverse grip catheter, like the MIC. I just like that extra degree of support.
I'm surprised that you can select them with a Cobra. That just seems like the wrong shape to get into those guys. Has that been successful for you?
Yeah. Actually, it's worked most of the time.
Nice.
Reviews. Yeah, it works.
I must just be doing it wrong. No,
no, it works for, and particularly for the bronchial arteries that arise kind of at the arch. I think it works pretty well. With that being said, I might be the minority there because I know a lot of folks do like the reverse curve catheter, SIM1 or a MIC, but it works well enough. I feel like it's stable enough for me to get my micro.
Just to go back, you said you like to do a flush aortogram, right? So for that, where do you keep the pigtail, and then what's your rate?
Yeah. So I put it in the ascending. So because I definitely want to catch the subclavians, right? So because there are those other vessels that can, those bronchos that can arise from subclavian, and I typically go 15/30 just for my flush aortogram. I do it on a more of a straight AP as opposed to a candy cane, just because I think that with that steep LAO that we get from a candy cane shot, you get some double density and kind of overlapping the ostia quite a bit. So I like the kind of straight AP for my flush aortograms.
Okay, and then do you run it all the way down and see if stuff comes off the phrenics too? So it's a pretty big field of view. Wow, that's neat. Yeah.
The phrenics are typically, I'm most concerned about the phrenics for anything by the lung bases, obviously, right? For anything in the upper bases, like your classic TB patient and whatnot, it's really unlikely that you would get a feeder from the phrenics going all the way up, right? Granted, if the patient has had multiple embolizations in the past, anything goes, right? But if it's your first patient, usually if it's upper lobe, the phrenics, you could definitely shoot it, but it's probably
not going to help. Maybe not going to help.
So likely lower yield.
Okay, so you selected, and then what micro do you like to use, or at least what size micro do you guys recommend?
Yeah, so I typically like something small. So the True Select is great. Before we had the True Select, so that's Boston size, as you know, the True Select 2 French has an 021 ID, fantastic, great flow rates and great trackability. Before we had that, I would go with the Echelon 14.7 French, fantastic catheter. The flow rates are obviously a little less, given the ID is smaller, but those two is great. If it's quite a beefy bronchial where there's a lot of blood flow going through it, then I prefer the True Select, just because you need those flow rates to really kind of opacify things. But truthfully, those two, as long as it's small, to me, I like the small microcatheters primarily because I like the flow rates to be maintained, so to speak. As if I had a large beefy microcatheter, and this kind of moving forward a little bit, I use glue for all my embolizations instead of particles. So I want that flow rate to push the glue as distal as possible. Okay.
Gotcha.
I know some folks, if you don't want to use NBCA, Onyx is I have some partners that like to use Onyx with a balloon occlusion microcatheter to really get that distal penetration. Like a Scepter or Sniper, those are relatively stiff for me. And there's that BackTable prep, which is kind of annoying for me. So I'm lazy. So I just use a standard end-hole catheter and glue. But we can talk about embolics.
Yeah, for sure. Yeah. Okay. So then what's your rate that you like to do through your microcatheter?
Yeah. So the standard kind of back to the principles of, the size of the microcatheter as your good flow rate, like 2 for 10 or 2 for 12, whatever they can get me. And I hold it out. So if it's 2 for 10 or 2 for 16, you really want to hold it out, right? Because you'll see the abnormal vessels, right? That's not what you want to look for. You want to look for any kind of fistulas, any kind of early draining vein, right? You really want to look for anything that would bring your particles to the left side of the heart and cause a stroke. And a bronchial, so any kind of fistula between the bronchial artery and the pulmonary artery, not a big deal. It's just going to go to the lung, not a problem. But you got to look for the pulmonary veins, right? That's what the big issue is. They're pretty uncommon, right? And I've only really seen it in the setting of a tumor, right? So there's a patient that I think had maybe mesothelioma. I'm not entirely sure, but some kind of pleural-based disease, pretty large tumor involving the right lower lobe. And there was an embolization, or we did a run, and you saw essentially pretty early filling of the pulmonary vein. And it was obviously, we didn't really have, we just had to proceed with embolization with liquid, but you can kind of get that a little bit. But anyway, that's what you want to look for, any kind of pulmonary vein filling. Aside from that, the artery of Adamkiewicz, right? So that's a classic kind of thing you want to look for.
Let's talk about that real fast before you move on, because I feel like we have a pretty broad audience, so not everyone might know what that is. But yeah, for the uninitiated, that sounds bad. What is that?
Yeah, the artery of Adamkiewicz, one of the primary arterial supplies to the anterior spinal artery. Having particles go through that artery of Adamkiewicz can lead to kind of an anterior spinal infarction. And I might be kind of giving it off a little bit, but essentially it's a large supply to the spinal cord that you should not embolize with particle embolic. I mean, if you close it off proximally with coils, which again, we shouldn't do coils, but nonetheless, if you do, or maybe some glue proximally, it's not a problem. But it's when you get small particles deep into the spinal cord, that's when it becomes an issue.
Okay. All right. Thanks for that aside. Thanks for the side quest. Yes. Excellent. Yes. I think so. You already touched a little bit on your choice of embolic, but let's kind of talk about all the possible options for embolics.
Yeah.
And then kind of like pros and cons, and then why you settled on glue as your jam. And it can't just be because glue is awesome, because that's not a great reason, Alex.
Of course. So the classic embolic that I think we used back in our fellowship days when we were in training was PVA. It's cheap and it works well. It's relatively, it's not tightly calibrated, but I think it's 350 to 5 or something like that. I haven't used PVA since we were fellows, but that's kind of the classic particle embolic that we've used. It has lots of data behind it and it works well. So, a lot of folks use it still. Here at UC, we don't really use PVA. We'll use Embospheres, right? And depending on which attending is doing it, either 3 to 5s or 5 to 7s. The general idea is that you do not want to use anything smaller than essentially 300 microns in terms of size, right? I think there was one cadaver study done maybe in the 70s that showed that the size of the anastomoses between the bronchial arteries and the pulmonary arteries was somewhere along the lines of 75 to 325 microns. So you want to stay above that size. And so 3 to 5s works well. There's some studies that show that 5 to 7s works well too. And so if you see early filling or any kind of other vessel, be it pulmonary artery or pulmonary vein, some people just jump straight to 5 to 7s, kind of block up those anastomoses / collaterals up front, and then kind of back up with the 3 to 5s. So that's that for the particles. Then we kind of go down the road of the liquids, right? So either Onyx or NBCA. I like the NBCA primarily. There's one study that compared, I believe it's retrospective. We need to kind of look into it a little bit, but there was one study that compared NBCA with particle embolization that showed that there's a lower instance of recurrent hemoptysis following glue. And so with that, I've just kind of completely switched over to glue. I think in our fellowship, where some folks were doing particles and some folks were doing liquid. With glue, aside from that one paper, which again, plus minus, if it's a single center retrospective study, glue is also quicker, right? So I spend less time kind of doing that. And I feel like if you shut down a vessel with glue, that vessel's not coming back, right? So just along the same lines of like lowering the incidence of recurrent hemoptysis.
What's your glue dilution for?
So I typically do around 5 to 6 of oil to one of glue, NBCA. We use Histocryl. At least I use Histocryl. Most of my partners have switched over from Trufil to Histocryl. I'm
like a glue noob. Like, I'm not noob, but like I don't use it as much as you do, right? So I just use whatever they have on the shelf, and usually they have to get it from Neuro to use it.
Yeah.
But like I'm not super informed about the differences between the different glue options that are on the market.
Well, I think there's a neuro indication for using it, for AVMs or whatnot. Histocryl is a skin adhesive. It's just like Dermabond. And so you essentially use it the same way, except, and Histocryl has this like a clear version, a blue version. It doesn't really matter all that much, but use it in the same way. And Trufil's maybe, I think last I checked was maybe 3,000 to 4,000 for 1 cc vial, whereas Histocryl is probably $5, 4.5. It's dirt cheap, and it works just as well. And some people say it might polymerize a little bit quicker, but I don't really notice that all too much per se. But it works. It works just as well. It is quite painful. So if you're doing the procedure under moderate sedation, that's when I'll let my nurses know, like, hey, look, we're about to embolize with glue, because if you don't, patients can report pretty severe pain along the site that you treat. So
I see.
A lot of burning pain along the ribs. Not uncommon, but it can be pretty severe. But it only lasts about 30 seconds or so a minute.
Can you walk me through the technique for glue embolic? How do you know your endpoint? How fast are you pushing? Is it aliquots, glue bullet, all of this stuff?
So there's a couple ways to mix glue, right? So I think the way we learned it in fellowship was we have a shot glass, you pour the glue into the shot glass, and then you pour in your oil and you stir it up.
Sorry, when you're saying oil too, you're saying Lipiodol, right?
Yes, Lipiodol.
Okay, cool, awesome. You put some canola oil and some Dermabond and mixes it up.
Exactly. No, it's Lipiodol. Yeah, so I pour the Lipiodol into a shot glass with the glue and you stir it. And I put typically some tantalum powder, but not always. The Histocryl doesn't come with tantalum powder. Trufil does. So you stir it up and you pull it out, and then you inject after flushing with D5, right? So you definitely need D5. I change gloves, get Nutel, all that, right? The way that I mix now, and I think it gets a little bit more of a kind of somewhat of a better mixture, is using a 3-way. I'm not sure if that really is much different from getting a shot glass and stirring it, but it makes me feel like I can kind of mix back and forth.
Just like a regular old 3-way?
Yeah, so I use a regular 3-way, and all the syringes I use are the polypropylene, the clear ones, the non-polycarbonate, because per IFU, you want and whenever you're using Lipiodol, per the IFU, you should have the polypropylene syringes and not the polycarbonates. So anyway, so I do that, and so the Histocryl comes in like 0.5 cc. They're not really vials per se, but 0.5 cc packages. And so I put that in a 3 cc syringe, put in 3 cc's of Lipiodol. So that's a 6-to-1 mixture. I mix it up, rinse everything with D5, and then I bring it to the patient, flush it all out. And then when I push essentially a continuous stream of glue.
You got a 1 cc syringe on there?
I put a 3.
Okay, you put 3 on there and you're just pushing through. Okay.
Pushing through. I don't use it. I don't do the aliquot. I know some people like it. I don't like it because I have this concern that if I push out the glue aliquot, the glue will start to fragment and I won't know exactly where it's going to go if there's a degree of reflux, right? These vessels can shut down pretty quickly. And so if I continue to push the aliquot, there's gonna be some scraps of glue that's stuck along the walls of the microcatheter. And I really don't know where all the embolic is going. So I have this fear. So I just do the continuous push. And then once I start, so essentially continuous push, and you see these drops of the oil kind of NBCA mixture, and you kind of see it just like a taste, for instance. You see these kind of droplets kind of go distally. And I always stop before I get any degree of reflux. Okay. And once I see any kind of reflux, then I stop. Ideally, I stop just when the glue is at the tip of the catheter.
Oh, okay. So you go all the way out and then it's at the tip. And then what?
So then after that, then I wait. So I wait. If it's a 6-to-1, If it's 6-1, I usually wait 30 to 40 seconds. I want the glue to harden completely so I can have a nice kind of clean break, so to speak. Okay.
Gotcha. Okay.
Wait 30 to 40 seconds. So, and then I pull, right? And I pull with
Okay.
pull quickly.
Yank with some force. Okay.
Mm-hmm.
Okay. Couple follow-up questions. Whenever I image the pulmonary tree, there's tons of motion artifact from breathing, right? So do you have like anesthesia hold a breath while you're embolizing, or are you able to see because of the tantalum powder and Lipiodol, like, are you able to see it so well that you feel very confident?
Yeah, so I feel pretty confident. I don't have the anesthesia hold respiration. I do mag in. I increase the floral flavor, right? Increase the dose of the fluoro.
But you're able to see no issues. Okay. And then like the 30 to 40 seconds is basically just to harden the glue, but not have it be stuck to the end of the microcatheter. Is that right?
Yeah.
Okay.
Because I have done it such that you inject and you pull, which also works for a lot of folks. And I still do that sometimes, but I definitely wait and pull for a cleaner break. I've noticed that a few times, or, if I inject and then pull and I have some reflux, then I'm pulling this glob of glue with me to the 5-inch catheter.
Have you ever had the microcatheter break on you when you pull?
I have not.
Sorry, I brought that up.
I have not, thankfully. Yeah, we use glue, a lot here, because it's cheap and it's fast. So
yeah,
but thankfully,
Very
nothing
cool.
has broken. Knock on wood. No, knock, but yeah.
All right. So then is it usually just like a single bronchial artery that's supplying and causing the problem? And like once you found the source, you're like, all right, I feel confident? Or how many times do you have to open up another microcatheter, go back in and like check the rest of them?
Yeah. So with that clean break, if you can flush out the glue from the microcatheter, then you might be able to reuse it. Doesn't work well all the time, but sometimes you can if you want to save $700 to $800, however much that the microcatheter costs. But to answer your question, I always go back to the flush aortogram, right, to see if there's other kind of hypertrophied tortuous vessels that are worth treating. I have a very low threshold to sniff around for that additional artery, right? The rate of recurrence is not. It's not low, right? In some instances, 5, 15, and even 20% risk of recurrence. So I always look around for the other vessels. If it's an upper lobe and there's hypertrophied internal mammary, I always kind of at least get a catheter in the vessel to shoot it, just to say that you shot it. If it's a lower lobe, the phrenics are not, I also go for the phrenics in that scenario. I just really don't want to come back, or worse, have one of my partners come back for me.
I know, right? Nothing worse than having your partner like come back and deal with your incomplete embolization.
Yeah, absolutely.
So what do you quote for patients as the success rate of the procedure, like on the initial run?
Yeah, so I tell patients that it works well, like more than 90% for sure. And I think the literature, that's what's reported in the literature. And I think after doing this for so many years now, I think that number is quite accurate. Thankfully, it works pretty well. It works very, very well. And yeah, most patients are pretty happy with it.
And then we really have talked pretty significantly about the complications already. We talked about stroke, spinal cord ischemia, and then just all the regular angiogram complications of infection, bleeding, that kind of stuff. Any special postoperative instructions you give these folks?
The biggest one are the neurochecks, right? So if they're going to the ICU, which a lot of the patients are, not a lot, but some of these patients are already in ICU because they're intubated and whatnot, right? Neurochecks is probably the most important thing to look for, or to request, I should say, like 1 or 2 hour neurochecks, just to make sure there isn't any kind of neurodeficits, right? Knock on wood, again, I haven't had any issues like that, but the data is what it is with respect to the risk of stroke or neurologic compromise. That's probably the biggest one. Otherwise, same thing with the groin, checking the groins after your closure and all that. So
all the good stuff. All right, cool. And then anything else you think audience should know, like, okay, here's one. Have you had any issues where you've had like a really difficult selection for a bronchial artery? And then like, what did you do to get out of it?
Yeah. I remember a couple of cases where, let's say the Cobra didn't work and I did a reverse curve, like a SIM or a MIC, and that didn't work. what I did in those, a few scenarios where I didn't have any stability, because that's what I really want, just some degree of stability to get a microphone there. You don't need a ton, but what has been helpful for me was to get a long sheath. Again, this is very uncommon. Usually a Cobra or reverse curve catheter would be sufficient, but if you're not having a lot of support on the back end, then you can put up a 5 French or 6 French. It could be it could be a straight or any kind of curved sheath for that stability.
Do you want like that sheath, like basically all the way up into the thoracic aorta, like almost up to where the bronchial arteries are?
Yes,
okay.
yes.
Got it.
These are older patients with tortuous iliac vessels that don't really give you a lot of, kind of one-to-one torqueability. So you want to kind of create that stability with the sheath. But again, that's very kind of, I maybe know one patient that I had to do, maybe two that I had to do it for. It works pretty, the 5 French catheter works pretty darn well.
No, it sounds like we kind of covered most of it. Anything I'm forgetting, Alex?
You really just want to look for the artery bedamquits and any kind of fistulas, early draining veins. That's probably the biggest thing. Glue is tough, but I mean, just with a little bit of experience, I think it works pretty well, and that's kind of what I would advocate. If not, then the Onyx works well as well. But I've seen Onyx, I've seen recanalization with Onyx as well. So I feel like, again, just anecdotally, I feel like NBCA is more of a durable embolization compared to the more cohesive lava or Onyx, whatever you want to call it.
Do you think the patients have a lot of pain with glue? Does that continue after the procedure, or compared to particle embolization, or is that really just at the time of insertion?
Yeah, just typically for the time of the injection, primarily because it burns. It burns quite a bit. I'm not sure if you've ever used the Dermabond on yourself. I've done it for a handful of cuts and scrapes, and it burns quite a bit. And Histoacryl itself burns, I think, more so than Dermabond, just because of the formulation. So once that kind of goes away, then it doesn't really cause much issue afterwards. So.
Cool. Okay, cool. Let's just pause for a second. We'll break the wall, pause. Let's think if there's anything else that we need to talk about for it.
Let's see. So indications, contraindications.
Yeah, we kind of went through it. Patient population. Is there anybody where you're like, I don't think this person is going to be a good candidate for bronchial artery embolization?
Yeah, that's a good question. So relatively low threshold to pull the trigger on somebody with because I like doing the procedure and it works pretty well. But there are some patients who it's their first episode of hemoptysis, and they're coughing up maybe, I don't know, half of a teaspoon, right? And it's completely resolved with inhaled TXA, whatever, right? I think a case can be made for conservative management, and we can revisit it if and when, especially if they have like pneumonia or something that can be fixed, right?
Sure, like a treatable cause of the hemoptysis.
Yeah.
Okay, got it. Do you ever do it for outpatients, or is it pretty much always just intubated inpatients or inpatients?
Yeah, the vast majority is inpatient for sure. I probably know 1 or 2 cases where it was an outpatient referral for hemoptysis. In that scenario, we call the patient and see what they're doing, and get them fast tracked before the procedure, because it not definitely, but it's usually an inpatient kind of issue to manage.
Oh yeah. I mean, we've all seen like hemoptysis, life-threatening hemoptysis, and these patients can just decompensate so quickly. So I love hearing about the multidisciplinary approach that you guys have, and that you have kind of this algorithm in place of how you treat them. And then do you see these folks in follow-up, like after they get discharged, or does
Pulm/ICU typically kind of manage these patients afterwards? They manage these patients beforehand, right? We have as mentioned, great Pulm service, and definitely kind of steering the ship. There is some debate out there about the utility of a bronch, right? Because when they kind of get in there, there's usually a lot of blood and they can't really figure things out. And I think a lot of that maybe has to do with kind of institutional experience. We really kind of trust our interventional pulm guys, and they not only diagnostically very good, but they can also kind of really stabilize the situation for us to kind of get in there and take care of the patient without worrying that they're going to bleed out on the table. Oh, for sure. Yeah. No worse place to code other than maybe like nuclear medicine. Terrible place to code. Yeah. Oh, yeah. Oh, yeah. No, that's yeah. When we do code, it's like I slowly back away from the lab. No, you don't. It's like, yeah. Well, Dr. Lam, thanks so much for coming on the show.
It's always just great to see a friendly face, honestly. I'm just like blown away by your expertise in this situation and just how like glue is like your favorite embolic for this now compared to what we were doing in fellowship. It's just super cool to see.
Yeah, no, it's great. It's always good to talk with you, Dr. Baheti. I mean, I really like this procedure. It works very well, and it really can help. Yeah. You really can help patients and it kind of not really bring them back to life, but really fix a situation that can be considered unfixable before all this kind of started developing.
Gosh, yeah. And that's why IR is the best. Boom. The end.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Baheti,
Michael Barraza, Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legretio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.